Okay, hey guys, so we're doing chapter 12 on behavioral emergencies. We cover quite a bit on this. This is going to have a lot of my soapbox and my personal thoughts. I hope it helps. So we're going to get going here. As soon as I get my computer to work. There we go. So we're going to discuss psychiatrics, behaviors that pose a risk to the EMR patient and others, special patient population, patients with special needs, and how to deal with that while waiting on emergency medical personnel to arrive, patients with special challenges, and recognizing and reporting abuse and neglect. So this is going to be a kind of touchy chapter. So EMRs need to give psychological support as well as emergency care. Factors contributing to behavior changes, medical conditions, physical traumas, psychiatric illnesses, mind-altering substances, situational stresses. These can all affect how someone reacts or completely changes who a person is from normal. As always, we're going to do an assessment, just like any other call. I've talked about this. There will always be an assessment with every patient. So we want to complete that scene size up. Being especially careful to make sure the scene is safe. With these behavioral emergencies, like I said, sometimes people are not who they normally are, so we have to be very vigilant and observant when we arrive on that scene. If patients are oriented and responsive, complete that primary survey, observe the patient's responsiveness, airway breathing, and measure a pulse. History should follow the sample format. By now, I hope you remember what that is, but signs and symptoms, allergies, medications, past pertinent history, the last oral intake, and events leading up to. So you hear me say it all the time, read the room, read the patient, make sure it's safe. We're going to do that scene size up, but we want to also pay attention to our life threats. That's pretty important. We're going to do that secondary assessment. We should rule out any obvious injuries and focus on signs of medical illnesses. Take a set of vitals. Reassess stable patients every 15 minutes, unstable every 5. There will be test questions. Go ahead and let's make notes of that right there and that right there. Okay. Because we will be asking this in class. You will be asked this throughout your entire course. When are you going to assess? How often are you going to assess? So go ahead and learn those numbers right now. If you cannot complete an assessment, document the reason for not completing it, whether that patient became violent, whether it became a life-threatening situation, so we immediately jumped into CPR. Just be sure when you do your documentation that it is documented clearly and truthfully why we did not continue through our entire assessment. Behavioral emergencies are situations in which a person exhibits abnormal, unacceptable behavior that cannot be tolerated by patients themselves or by family, friends, and community. That definition is going to be on a quiz. Okay. What is a behavioral emergency? There's 5 factors that will contribute to this. So we've got medical conditions, things such as diabetes, respiratory conditions, strokes. I'm going to jump over to stroke real quick. There are people, and this happens in elderly all the time, where you take the sweetest old woman at the nursing home, she has a massive stroke, and now she cusses more than a sailor, and she's rude and inappropriate. You cannot hold this against them. This is a medical condition that we need to try to help them with. Medical conditions can be head injuries, high fevers, and infections. These can affect also excessive low blood or body temperature. Physical trauma conditions, head injuries. You notice that's on medical also. Injuries that result in shock and in inadequate blood supply to the brain. we're not firing correctly. Our brain's not getting fed the nutrition or the oxygen that it needs. So something in there switches, and it can cause these behavioral crises. Um, Psychiatric illnesses, so depression, panic, and psychotic behavior. Depression is a super important thing to understand. There are people battle with depression and you don't know it. Some of the um, caringest, happiest people in the world battle with depression. So once again, don't judge a book by its cover. Panic attacks. You will see these, and people can lose their minds during a panic attack. Um, Psychiatric behavior. Some people are just a little loopy, which goes right into this next one, the mind-altering substances. Alcohol. Most people have been around someone that has been inebriated, and it changes who they are. A wide variety of chemical substances, which we learned in our last chapter. Situational stresses, so death of a loved one or serious injury to a loved one, or I'm going to go, you guys respond to a really bad call, or you see something that's just horrific, it changes who you are. And I know I've touched on this on some other chapters. Reach out and talk to someone. Me right now, I see a therapist every 2 weeks. Not because I'm crazy, but because I've dealt with this right here. So situational stresses is a real thing. So you have to be mindful of not just your patient, but also anyone around that scene right now. So family members, relatives, neighbors. And then you also have to be um, on your toes with yourself and your partner. You guys got to take care of each other. What is a situational crisis? So it's a state of emotional upset or turmoil caused by a sudden or disruptive event. Most situational crises are sudden and unexpected. They cannot be handled with a person's unusual coping mechanisms or usual coping mechanisms. Last only a short time and can cause social unacceptable, self-destructive, or dangerous behaviors. What I really want to focus on with this page right here is spouses, children, and you guys as responders, or me or my partner. Um, these events, they do happen suddenly. They are unexpected. Even if, for example, you've got an old couple and one of them has been going downhill slowly for years, and the whole family says, "Oh, we know the time it's coming, it's going to happen." It is still an unexpected thing when they have a cardiac arrest and their loved one dies. So we're still going to see some of this. I'm not saying everybody's going to go crazy. I'm going to say that there are emotions. Um, and sometimes people do not handle them well. Normal coping mechanisms, everybody's different. I've said in previous videos, I like hunting, fishing, camping, golfing. When I went through my really bad times, I had some different coping mechanisms. Um, you need to be prepared to keep an eye on each other, your patient, their families, and all that. Um, Phases of situational crisis. There are 4 emotional phases for each situational crisis. People may not experience each phase, but they will experience one or more emotional phases. So that high anxiety and emotional shock, um, we need to watch that. Denial is a huge one. Anger, this is the one that you really need to be careful with if you are on a scene dealing with someone, or family or neighbors, friends, and then remorse and grief. This is where we need to be very understanding. We have to control ourselves, which I'll talk about here in a minute, but we need to allow them to let it off. If they come to us and they need to talk or they need to let some of this off, we need to be there for them, but never get yourself in a bad situation, especially with that anger. I'll talk about stuff later. So high anxiety is characterized by flushed or red face, rapid breathing, rapid speech, increased activity, loud or screaming voices, and general agitation. Um, so the ones we really need to watch is this one, and be prepared for this one. So the only reason I highlight those, rapid breathing, we could actually, not we, our patient or patient's family or friend could actually start to hyperventilate. And now we've got two patients. Um, Rapid speech, let them rattle if they need to rattle. Increased activity, we just need to make sure they're not doing anything stupid. Um, Everybody handles this a little differently. Just kind of be aware of what's going on in your surroundings, because your scene needs to stay safe the entire time. The scene is always changing, so we just need to have an idea where people are and what they're doing. Loud and screaming voices, the reason I put that on there is to prepare you. There are bad calls or sad, where relatives or friends or family, they will, as they're accepting, as they're breaking down, they will scream and yell. They don't understand, they're kind of in denial. Um, and agitation is to be expected. Just remember what they're going through. Emotional shock is often a result of sudden illness, accident, or sudden death of a loved one. Emotional shock's characterized by the cool, clammy skin, which we know is shock, right? That's just shock. You don't have to know all the different types of shock. Cool, clammy skin, it's shock. We'll learn how to differentiate later. A rapid, weak pulse, vomiting and nausea. We've all had a moment where we got so scared or so upset that we felt sick. And general inactivity or weakness. Sometimes people just drop to the ground. They drop to their knees. They're sobbing. They're screaming. They're crying. They're feeling sick. That's that emotional shock. And it, like it says up here, it's going to be a sudden illness nobody expected. It's going to be a car wreck or accidental gunshot. It's going to be something that nobody could predict, nobody could prevent. It just happened. Um, so denial, we're going to refuse to accept the fact that an event has occurred. Your response should be as follows. So allow that patient to express denial. Do not argue with the patient, and try to understand emotional and psychological trauma that the patient is experiencing. I'm not telling you to put yourself in their shoes. What I'm saying is remember to be mindful of what they're going through. I'm going to go ahead and go down my soapbox I was going to a few slides ago. So as a first responder, as an EMT, advanced paramedic, whatever you might be, this sounds cold and I don't mean it. One, it's not your emergency, it's theirs. It's not about you at all. Even if you were the responder on that scene. Secondly, sometimes it's hard, and this is a mental thing that you have got to teach yourself. We hold it together. We hold those feelings inside until we're away from those family members or those patients. You can get in that truck and you can cry your eyes out with your partner. You can come back to the base and talk to your director. You can do whatever you need. I go to a counselor and I talk to my partners. But when we are with those families, I'm not saying be emotionless. I'm saying you cannot show panic. You cannot show, you can't be over in the corner screaming, because we are there for them. Their emergency, not yours. Then there's anger, normal human response to emotional overload or frustration, may follow denial or may replace denial. People may vent angry feelings towards you. Do not take it personal. A person's anger personally, frustration, and a sense of helplessness can often build to anger. Always be professional and remain calm. This chapter has so much that I could just go on and on about. So if they come at you and they are trying to blame you, or remember that you put the time in and you did everything you possibly could. Mistakes are going to be made on calls. I'm going to be the first one to admit it and tell you I make mistakes on calls. I've had a few very, very serious bad calls, and there were mistakes made. Does that mean that I did not do my very best? No. I gave it everything I had. Mistakes were made. I learned from them. I will never make those mistakes again. Um, so the point of that is, if you get one of these and there's mistakes made, it doesn't mean you failed. It doesn't mean you're a bad medic. What it means is that you did what you could in that situation. These people might come to you and try to blame you and try to point fingers. Don't yell back at them. Don't argue with them. Express your grief. Express how sorry you are. Um, I'm going to tell you, don't take it personal. And I am the worst hypocrite in the world, um, because I always take it personal. That's why I go to a therapist. Um, we do this because we care about people. So yes, it affects us. I'm going to continue to harp on the mental side of this until you talk to someone, talk to a therapist, talk to your boss, talk to your partner. Um, and then that frustration and sense of helplessness can often build to anger. Always be professional. Everybody's different. When I lose someone, whether I know that I can't save them and I gave it my all, or whether I did my very best, they should have been saved and they didn't, whether it's a greater power, no matter what it is. Um, you might feel this helplessness or this. My personal feeling is my job's to save them and I didn't do my job. And I take that super personal. Um, you're not supposed to do that. If you do that, once again, go see a counselor. Um, we're going to move on. I think I got everything out of the way I wanted to say. So acceptance of a situation may lead to remorse or grief. So this picture is perfect. Be there for them. Let them grieve. Let them talk. Let them cry. Um, people may feel guilty or apologetic about their behavior. Very simple. I understand. I would have acted the same way. You're perfectly fine. No hard feelings. I'm sorry for your loss. It's that simple. You stay calm and collected. You can have your breakdown after we're away from that family or those patients or whoever it might be. Your role as an EMR, so follow steps of patient assessment sequence. So we want to perform that scene size up, make sure everything's safe. Who do we need? Who do we have? Do I need further resources? All of that. Perform that primary assessment. That's where we're going to do that general impression where ABCs. We want to start getting an idea what's going on there. If there's life threats, we fix them right now. Obtain a patient's medical history using sample. Perform a secondary assessment. So we're going to start working on the secondary injuries that are not going to kill them. We're going to put Band-Aids on them if we need to. And provide ongoing reassessment. So when we are done assessing, we're going to reassess. I know it says every 5 or 15 minutes. A full body assessment on a trauma patient is going to take you about 2 to 3 minutes. If you are good at it, you can do head to toe. As soon as I'm done with that assessment and I've done my vitals, I'm going to start right back over. I'm looking for any changes every time I do an assessment. Most important assessment skill may be your ability to communicate with that patient. That is huge. I love my highlight. We're going to go ahead and just highlight that right there. This is a personal thing that I fully believe in. Building that rapport with your patient and your patient's family, I'm going to throw that in there, is monstrous. Because if the patient trusts you, that's huge. If the patient's family trusts and respects you, it's huge. And the way you do this, your communication is by education. So I've said it and said it and said it. Put the time in. This class is like 3 months. Work your butt off for 3 months. That way, when this call comes, you don't question what you're doing. You know what you're doing. And you have the ability to explain that to the patient and the patient's family. And I promise you, clear English, none of this medical terminology crap, just clean. This is what we're doing. This is what we did. This is why we did it. This is what was going on with that patient at that time, will be one of your most greatest assets. Learn to communicate, become educated, and then use that education to help these patients and family. So communicating with patients, we've kind of talked about this, talk to the person. So introduce yourself, ask the patient his or her name or what they would like to go by. Um, Ask what you can do to help them. Be honest, warm, caring, and empathetic. And position yourself at the eye level. So this guy down here, I need my pointer now. This dude right here is not a good example. Okay, this body language communicates an uncaring attitude. Why the hell did you get me out of bed at 2 in the morning? All you did was trip and hurt your knee. This is not what we want to make. This is not the first responder that we want. This guy up here, the top dude, this is what we're going for. This is what you should strive to be. We want to crouch down or seat yourself at the patient's level. We want to calmly, collectively talk to them. We are there for them. Essentially, that guy right there is paying my paycheck. I'm there because I care about him. This guy down here, he's a horrible example of what EMS is supposed to be. That's not what we want. Establish eye contact with the patient. Use a calm, steady voice to provide honest reassurance. Try not to let negative personal feelings interfere with your attempt to provide assistance. And simple acts of kindness can provide comfort and reassurance. So I told you I was going to have fun with this chapter. Where is there we go. So we already talked about this one. This right here, sometimes it's really, really hard to think about. We run on any child abuse or we run on elderly abuse or something like that. It's really hard to be there with a person who might be guilty of this. Or we run on a spouse who is just rude, just treats his other half just terrible. It's not our job to beat up on that person. It's our job to take care of the patient and be that patient's advocate. Simple acts of kindness can provide comfort and reassurance. This goes a mile. I'm not saying go out of your way. Some people do it naturally, some don't. Something as simple as on a rainy day, pushing a cart for an old lady, unloading groceries at Walmart for her because you see her struggling. It's not just in your job, it's off the job as well. One thing that I do, the perfect example, and I'm no better than anybody else, but when we take a patient transport, if we are traveling like towards the city, the sun is always shining in the back window of the bus or of the ambulance. So it's shining right in that patient's face. One thing that I do with every patient is I will tie a blanket and hang it over that back window. And that's the tiniest, simplest thing. But I've had more people thank me for that because it was just a step that I took that I didn't have to. So taking those little steps of what would I like someone to do for me, and then you do it for that patient, that is a huge step. I can't push that. Restatement. So rephrasing a person's own words and thoughts and repeating them back, that lets them know you are listening. That lets them know that you are taking it in and paying attention to them. Be honest and give patient hope, but do not give them false hope. This is kind of a tough one in certain situations. We want them to feel comfortable. We want them to know that they are in good hands, but we also don't want to lie to them. If something is going bad and they are with it enough to ask us, we need to tell them, this is what's going on. I'm going to do X, Y, and Z and do my very best. Just stay calm, keep talking to me. This goes back to that communication. We educate them as we're doing it. If they feel that we know what we're doing, they are naturally going to be a little bit calmer. Redirection, help focus patients' attention on immediate situations or crises. This one can go 10,000 different directions. Once again, communication and education are key. Let's keep that patient with us, talking to us, focused on the here and now. Once again, redirection. Use redirection to elevate a patient's expressed concerns. Move a patient to a quiet or more private location. So this is a big one, depending on the call. Can we move this patient somewhere away from danger, away from that abusive spouse, or that abusive caregiver in the nursing home? Can we get them safely somewhere else and then do our talking, our communicating? Empathy, imagine yourself in another person's situation and share his or her feelings or ideas. This is exactly what I meant a second ago. But put yourself in their shoes. How would you want to be treated? What extra steps would you admire if they took for you? Then you take it for them. Empathy is one of the most helpful concepts you can use, going back to that communication education thing we talked about, and use a calm and caring approach. We don't come in there yelling at people or throwing our hands around and cussing and because we're up at 2 in the morning because of toe pain. Yes, sometimes it's annoying, but when we get in that truck with that patient or we get in that home with that patient, that is our patient. We're there for them. So we need to keep that calm, caring approach. Principles for assessing patients with behavioral problems. So we need to identify ourselves and let the patient know you are there to help. Um, Inform patient what you're going to be doing. You should do this with every patient. Ask questions in a calm, reassuring voice. Once again, we're going to get that nice, soft voice when we talk to our patient. Allow patients to tell you what happened. Do not be judgmental. Show you're listening by using restatement and redirection. Acknowledge patient's feelings. Express patient's mental status or assess the patient's mental status. So there's a couple on here I want to hit. We talked about you always tell them what you're doing. Identify yourself. Let's see, ask questions, calm voice. This one, we never judge, no matter what the situation. Our job is to give them care. Um, right here, never say I understand or I get it or and let them talk, let them express their feelings. This is their emergency, this is their traumatic event. You let them have that moment. It's never about you, it's always about that patient. Assess the patient's mental status. You can do this very easily. This is kind of like checking to see if they're alert and oriented. So ask simple, very clear questions that they should know the answer to. Um, and that'll tell you kind of where they're at, year, place. Um, Grab that picture of their grandkid and say, "Hey, who's this? How many quarters are in a dollar?" Communication with the patient with developmental disabilities. CDC data indicates 1 in 6 children has a developmental disability. Um, Developmental disabilities range from learning disabilities and developmental delay to autism, spectrum disorder, Down syndrome. There's a whole bunch of them out there. So this one, learning disabilities, there's so many out there. ADHD is a learning disability. I told you like in chapter 1, I'm a severe dyslexic. That's a learning disability. Does that mean I need you to talk slow and draw cut pictures with crayons? No. Is that a bad thing to do with maybe this one right here? If that's the best way to communicate, do it. Use the family members um, or the caregivers or the neighbors who know this person, this child, this adult, whatever. Use what tools you have around you to communicate with these patients. Let's see, for example, patients with autism might avoid eye contact and want to be alone. Not look at objects when other person points them out, have trouble expressing their needs using typical words and motions, appear to be unaware when people talk to them, but respond to other sounds, have trouble adapting when their routine changes. That's a big one for autism. Um, pref- Prefer not to be held or touched. So this is why we need to use those caregivers, those parents, those neighbors, whoever might know this person. And this is just autism. I highly support people taking extra classes if this is what you want to do for a living. I took an autism class and I learned a ton in an hour and a half class. They are out there, they're available. Go take a class, learn about the disabilities, and you will be a better medic. You might only use it once a year, but it's something that's really handy to have. So performing crowd control may help reduce a patient's anxiety when there are too many people around. Um, Use your firefighters, use your police, build a wall. Let's keep the patient's privacy and anxiety low. Um, During your scene, size up of the scene, determine whether there's a crowd that might become hostile. It's better to ask for help early than wait till we're in trouble. So this can go schools, sporting events, concerts, anywhere where there's a group of people. And I use Walmart all the time because I have one in my town. Um, Walmart parking lot. There are looky-loos always wanting to be nosy. So we want to keep those people away. A lot of patients are already embarrassed that EMS is there, and so let's do our best to keep that patient's modesty and privacy. Um, and it's a dangerous situation if we're in big crowds. Um, our scene is not safe if we've got people hovering over us. So let's use our law enforcement. Let's use our firefighters. Um, Domestic violence, so commonly occurs, or common occurrence in today's society. It takes several different forms: elderly abuse, child abuse, spousal and domestic partner abuse. Now, when responding to a domestic call, maintain safety for all rescuers as well as the patient. I've said it 10,000 times: you, your partner, then the patient. Anytime I'm going on something like a spousal domestic, if I get a call for a domestic, I'm not rolling up until law enforcement has told me it's safe. Um, I want to get there. I want to help that person. I might have to stage 2 or 3 blocks back, and it drives me nuts. But I'm no good if I'm laying on the ground, knocked out, stabbed, shot, any of that. So elderly abuse, it's a little bit different. Child abuse, those are a little bit different, but we still need that scene safe for us to enter. Um, when responding to a domestic call, conduct an effective assessment and treatment, understand requirements for reposting abuse to your state, or reporting abuse, sorry. And then physical signs and symptoms are broken bones, cuts, head injuries, bruises, burns, scars from old injuries, injuries in various stages of healing or internal injuries. So I'm gonna back up one. Um, these are the things where you and your partner almost need to be able to read each other. I work in a small service, like I've said, and no matter who my partner is that day, that night, we have worked enough together that we can give each other glances and know what the other one's thinking. That's huge. Um, Never jump to conclusion, but keep a open mind. We'll go with that. So if I come up on broken bones or cuts, that the stories don't quite add up, I'm going to keep that in mind, and I'm going to report that to the receiving facility. I might pull a nurse out of a room once I'm there and go, "Hey, not saying it is or it isn't, but this is what I seen. This is what I was told. It's not adding up for me." I will go to my supervisor or my director and go, "Hey, this is what I'm thinking. I have no proof." A lot of times they will have you fill out an incident report, and they can help you report these to the state, um, if need be. So head injuries, pretty much whatever story you get from the patient or the patient's family or the caregiver needs to make sense. You need to be able to play that out in your mind and go, yeah, I can see that happening. Bruises, I'm going to tell you, old people get bruises all the time. We know that. Kids are kids, but we need to pay attention to the type of bruises. It says down here, various stages. If there's a lot of bruises and there's some of them yellow ones, and then there's some black ones, there's some purple ones. Okay, these are multiple different times that those bruises are taking place. I'm going to be a little bit more leery of what's going on. Burns, we could have a whole chapter. We will have a chapter on burns, but abuseful burns, you'll know them when you see them. Cigarette burns, what's called gloving, where happens to children, where people will like stick their hands or their feet or even their genitals in a bathtub of super super hot water, and it actually looks like a glove. It'll come up and like stop where the water stopped, and then everything else is normal. So we need to pay attention to that. Man, I hate this chapter. Emotional symptoms. So depression, suicide attempts, abuse of alcohol and drugs, feeling of anxiety, depression, or hopelessness. Abusers may be paranoid, oversensitive, obsessive, or threatening. Um, Once again, abusers can be a big brother, a big sister, a caregiver, a parent. Um, an abuser can be anybody. And the signs we're going to look for from the abuser is the paranoid, like they hover over, they try to over or try to answer questions for the patient. Um, if they even think you're accusing them, they become very sensitive and like almost angry with you. Um, I haven't personally seen threatening. Let's see. So your patients are going to show depression and suicidal attempts. So this is multiple attempts. Um, you definitely know you need to be looking at what's going on. This person right here needs help, but they're probably in a lot of cases either ashamed or scared because of this right here. Um, Alcohol and drug abuse, yes, it can be what people use to get away from it all, to be in their happy place. Just because someone's drinking or doing drugs, though, doesn't mean they're abused. Feeling of anxious distress or hopelessness. Sometimes people just hit rock bottom. And then sometimes, like I said, read the room, read the people. Sometimes it's because they have been beat down and they feel like they're just nothing. They're at rock bottom. If you suspect abuse, your responsibility is to maintain safety for yourself and your partner and your patient. Um, Try to separate the patient from the abuser. Sometimes this is where law enforcement comes in. Try to keep from judging the patient or the abuser, not our job. Presence of law enforcement personnel may be helpful. Okay. And learn requirements for reporting abuse in your state. Talk to your director, talk to your supervisor, whoever, and figure that out. I personally have only had to do a couple of these reports. They're terrible. You feel bad. You stress over it. Um, the hardest one here is trying to separate that patient from the abuser, because a lot of times, like we talked about a slide or two ago, that abuser is going to be hovering. They're going to be like, they are listening to every word said. There's a good chance that they're going to be giving looks to that patient, letting that patient know you better not say anything. Um, so this is where law enforcement comes in. You can be like, hey, I really need so and so out of the picture. I can't allow you in the truck. I'm sorry, it's against our protocol, whatever you need to do to give that patient the ability to open up. Cycles of abuse. So the tension phase, the abuser becomes angry and often blames the victim. The explosive phase, the abuser becomes enraged and loses control, as well as the ability to think clearly. A lot of times they'll come right back and apologize after they do this, because they're overthinking it. They're like, oh my God, I just gave myself away. So they'll come back and try to make up for it. Abuser makes promises which are seldom kept. So violent patients, we are there for the patient, but we are also there to keep ourselves safe. So immediately attempt to establish verbal eye contact with the patient, check with family and friends about patient's past history of violence. Signs of potential violence is history of violence, yelling, and verbal threats. Don't get yourself cornered. It might say that in a minute. I don't know. We'll go over that in a second. Signs of potential violence are loud, obscene, and bizarre speech, pacing, inability to sit still, and protection of personal space. Abuse of drugs and alcohol can come into play here. Never force a potentially violent patient into a corner. and do not allow yourself to be cut off from a route of retreat. That's where I was going a second ago. We cannot corner these people. The best thing we can do is keep a distance, keep eye contact, stay calm, be vigilant of the surroundings, know what is around that patient. So if they go to grab something, whether it's a weapon, a knife, whatever, we have time to backtrack and get out of there. And that goes into the next one. Always, always, always allow yourself an exit. Don't get between, or don't let that patient, that combative patient, get between you and the exit. Um, because we need to be able to hightail it out of there if need be. Have only one person talk with the patient. So um, whoever's communicating should be rescuer with whom the patient seems to have the best rapport. Anticipate need to summon law enforcement personnel if all else fails. So me personally, I've only had two patients in my entire career that just absolutely hated my guts. I mean, they wanted nothing to do with me. The way we usually approach this is my partner and I enter. Um, we try to communicate, hey, my name's so and so, what's going on today? And whichever one of us gets the worst backlash is the one that's going to back up. I don't leave my partner alone ever. Um, if it's me that stays in the room with that person, I'm going to give that look to my partner and I might be like, call PD. We're going to get the police department headed our way. And I'm going to calmly talk to them, keeping my distance. I always want to know where my partner is, because I feel like that they're my responsibility and I'm their responsibility. And we maintain that contact and we just talk to that person. They can be mad as can be, and I just try to keep it going until law enforcement can get there to give me a hand. Violence against DMARS. So factors that increase the risk of violence in the workplace: working alone or in small numbers, working late at night or early in the morning, working on high crime areas, or working in community settings. So, like I said, I work in a very small town. There's two of us. Me and my partner are running calls, usually on 24, 36-hour shifts. Yes, we can call PD. Yes, we can call fire. We know our town well enough that when we get dispatched out to a certain area, which goes down here to high crime area, when we go to certain areas, we automatically know we're calling for backup. Didn't mean to do that, sorry. Working late at night or early mornings, like I said, we do 12, 24, 36-hour shifts. So we are up. I mean, we take naps and stuff, but we respond in the middle of the night. We respond in the middle of the day. So you never know. Working in the community settings, that is where we're going to have a lot of people. And this is why we have to maintain a safe scene. Your scene is always changing, so it is never 100% safe. There's always movement. You just need to keep an eye on what is going on, who's around. Go ahead and keep them crowds back. Be alert when you respond to a call that has an increased chance of violence, including the following situation: crime scenes, incidents involving gangs, large gatherings of hostile or potentially hostile people, and domestic disputes. So crime scenes, we're not going in until cops tell us we can. Is there always a chance that someone's going to come in behind us and commit another violent crime? Yes, it's very possible. But I will never go to a crime scene without some kind of support. Incidents involving gangs. Luckily, I don't have gangs where I live. I can't speak a whole lot on this, but I would say that you definitely need some law enforcement backing you. Know how to communicate without making people mad. Large gatherings, we kind of talked about that. Hostile events where the only thing that pops in my head right now is like political stuff, because right now we're in the election season. But anytime that you've got two different parties who might be trying to discuss something or work something out, that's a hostile possibility right there. And then domestic disputes, we already talked about. If it's domestic, I'm calling LE, law enforcement, to come help me. Ways to minimize risk of injury. Take steps to keep yourself and other rescuers safe at the scene. Always keep an escape route open between you and your patient. I will use our fire department. A lot of times they'll respond with us. There's two of them, two of us. So we've got four people on scene. If I feel like the scene's just not quite safe enough for me, or I have that feeling someone might be coming up behind me, I will have them. I'm like, hey, can you watch the door? Um, just have that extra set of eyes in the back of my head. So prevention, the best way to avoid violence. Um, make sure you have an escape route in mind. Let's see. Armed patients. Oh, whole different ball game here. Uh, it's not your role to handle an armed patient unless you are a law enforcement officer. Be alert and summon assistance. Stay in your vehicle if you must wait for law enforcement officers. If you are confronted by an armed person, immediately attempt to withdraw. So you can be a medical hero. Do not try to go and disarm someone or confront them. Let the cops do that. Be alert and summon assistance. This is where we're calling law enforcement. This is where we're calling for backup. Stay in your vehicle. I'm going to tell you that if you roll up and it's an unsafe situation, there's an armed person, we're getting out of there. We're going 1, 2, 3, 4 blocks away and parking until it's safe to enter. And if you're confronted by that armed person, let's try to get out of there. Let's get away from that. Medical and legal considerations. So, if an emotional and disruptive patient agrees to be treated, few legal issues should be arised. If the patient who appears to be disruptive refuses treatment, you may have to provide care against patient's will. Get law enforcement there. Do not ever try to force someone who is already kind of mentally unstable into treatment. Um, get law enforcement. They can help. You must have a reasonable belief that the patient would harm themselves or others. At that point, we are going to have law enforcement. We are going to either restrain them by handcuff or we are going to soft restrain them onto our cot. You need to know your local protocols before you do that. If you're required to restrain a patient, consider these factors: patient's size and apparent strength, patient's gender, the type of abnormal behavior, the patient's mental status, and method of restraint. You may use reasonable force to defend yourself against an attack if you cannot get away. Seek assistance from law enforcement officers or from your medical director. Document conditions present. This is where we scan that room. We talked about it in the last chapter. We scan that entire room and we take mental screenshots of what we see and where it's at. And, whenever possible, a caregiver of the same sex should take the primary responsibility for care of the patient. It doesn't always work out that way. Sometimes there's two guys on a truck. Sometimes there's two women on a truck. Sometimes there's a man and a woman on a truck. Just like my shift, I'm working with a female partner. Nothing against that. I trust her 100%. But if I have an agitated female, there's a chance that maybe she doesn't like men. If she has a better rapport with my partner, then that's who's going to be taking that patient. Very seldom do you absolutely have to, but I'm going to jump over real quick and say if it is a sexual assault of some kind, definitely, even if you have to call up like your director or your supervisor or whoever, if we can get a female with a female or a male with a male in those situations, that's best case scenario. Many patients who fail at their first attempt will try committing suicide again. Underlining psychiatric diseases is unusual or is usually treatable. Review the risk factors that make it more likely that someone will consider or attempt suicide. So management, we're going to protect yourself and your partner and your patient from further harm. Obtain a complete history of the incident. Determine whether the patient still has a weapon or drugs on him or her. A lot of times these suicidal people, a lot of times we don't know what's going to happen. It just happens. Um, if you get stuck in a situation where they haven't done it, but you're on scene, law enforcement is going to try to handle this. Sometimes you have to talk to them. All you can do is be calm, collected, and listen. Don't tell them anything. You're going to listen to them. That is the best thing you can do. Attempted suicide management. So support the patient's ABCs. So at this point, they have attempted it, whether it's by gun, hanging, pills, drugs, whatever it might be. So we want to keep those ABCs top of the line. That's our airway, breathing, circulation, dressing the open wound. Um, we want to treat those life threats. So if we're hemorrhaging, we're going to fix that. That's a life threat. That goes with your C. Treat patients for spinal injuries. Do not judge the patient. They're down on their luck. They already hate life, obviously. So let's not judge them. We need to be compassionate, empathetic. Treat patients for injuries and conditions you discover during your assessment. That's when we do assessments, and provide emotional support. Post-traumatic stress disorder, a mental health or behavioral condition triggered by experiencing or witnessing a terrifying event. The symptoms include intrusive memories or traumatic events. Sorry, I had a fly on me. Avoidance of places, activities, and people that remind them of that event, negative feelings, emotional reactions. This is not only for your military. This is what pops in my head. It pops in every head. Oh my God. These soldiers, this can be police officers, can be firemen, this can be any EMS worker. One of the reasons yours truly had to go have therapy is because of this right here. So it does happen. We need, once again, to be very open, listen, understanding, and supportive. As an EMR, your job is to protect the patient from further harm, speak with the patient in a positive and supportive way, arrange for the patient to be transported to an appropriate medical facility. You can offer to get them help. When I get to the hospital, I've had these patients. I will pull that nurse aside, I'll pull that doctor aside, whatever, and go, hey, they express that they do want help. They don't want this as an outcome. So just, you're the advocate. You speak for that patient. Go ahead and be supportive. Sexual assault, we kind of touched a second ago. So psychological aspect of treating are important. You may have to delay all but most essential treatments until a responder of the same sex arrives. This is huge on these. Your first priority is medical well-being of the patient. Treat any injuries the person may have sustained. Once again, don't question them, don't judge them. You're there for them. You're their support. So sexual harassment is a crime. Do not remove clothing except to be given medical care. If you do need to take it off, let's put it in a bag, a trash bag. Let's keep it as original as possible. We need to keep all evidence clean and not contaminate that. Try to convince the patient not to bathe or use the toilet. Keep scene and evidence as undisturbed and intact as possible. Avoid aggressively questioning the patient. Don't ask, okay, tell me exactly what happened. It doesn't matter. We're there to treat that patient. Treat the patient with empathy. So death and dying, you will encounter death and dying as a natural, accidental, or intentional cause. Do whatever you can to meet the patient's medical needs. Most people are afraid of dying. Work through your personal feelings about death. This is what I was talking about earlier. It's their emergency, not yours. And this is also where I was talking about, you might have family members or someone who's screaming and crying. After these events, go get yourself help. I don't care how tough you think you are, and I'm really going to pick on the guys here for a minute. You are not made of iron. these things are going to affect you. If not now, it will be down the road. I really, really preach on this because I have suffered through this. I tried to be that tough guy. Um, and it changed who I was as a person for several months. Um, my family, my coworkers, everybody noticed that I had become someone different, um, because I didn't deal with it correctly. So if you deal with one of these, like accidental or intentional deaths or a natural death of someone you know, when you took it hard, go talk to someone, please. Consider psychological needs of the patient and his or her family. Do not be afraid to touch. Um, don't pat them on the back or rub their head. They're not your dog, but you can lay your hand on their shoulder. You can lay your hand on their leg. Um, do not be afraid to touch, make positive statements, but do not give false hope and provide comfort in any way you can. Take the person that you absolutely love the most in the world and imagine that that's that was the patient, or that's who's dying or death. How would you treat your family? Um, you got to be sympathetic here. Let them grieve, let them talk, let them cry. Um, provide emergency care is stressful for the EMRs. It is. EMR, EMT, I don't care. It's stressful. If you let stress build up without releasing it in a healthy way, it can begin to have negative effects on you and your performance. It does. Signs and symptoms of extreme stress: depression, the inability to sleep, weight changes, an increase in alcohol consumption and drug abuse, the inability to get along with family and coworkers, lack of interest in food and sex. Every one of these. Um, if you're good at what you do, you will notice you're going through these. You will notice the changes. And that's why I say don't wait till you hit this point, because when you hit that point, you're already stubborn. You're going to try to beat it on your own, and you can't. I promise you, go get help. To help prevent excess stress and relieve stress caused by critical incidences, psychologists have developed a critical incident stress debriefing process. CISD brings rescuers and trained personnel together to talk about rescue feelings, may help rescuers understand the signs and symptoms of stress and receive reassurance from a group leader, allows people to obtain more help from trained professionals if needed. Peer support is a process involving properly trained members of your department to provide confidential support to other members who is experiencing professional, emotional, and work-related problems. Um, Real quick, remember HIPAA when we did the legal chapter. So you can't just go out and talk to any Joe Blow about these bad calls. You need to, there's grief counselors. Check with your service. A lot of services have a counselor that can call in to talk to you and work with you. You can find a private therapist, just like I did, who specializes in trauma, who will help you work through these things. But don't go like telling your best friend, because he's going to tell his friend, and we've got HIPAA violations all over the place. So we're done with the chapter. Let's real quick run over these three review questions. So behavioral emergencies are a situation in which a person exhibits abnormal behavior that is deemed unacceptable by others, mild to moderate depression, anger that is justified by the situation, or strange behavior but is otherwise mentally stable. So a behavioral emergency is that abnormal behavior and it's unacceptable by others. So A, which of the following is not considered an emotional phase of situational crisis? So this is where we talked about the anger, the denial, the grief. We did not say that violence was one. Violence is never an acceptable phase. So D is not considered an emotional phase. And then three, when treating a patient with PSTD, one of your responsibilities is to protect the patient from harm, speak with the patient in an authoritative, forceful way, convince the patient to take care of the problem himself or herself, contact law enforcement immediately. So we never talk to a patient that way, in a forceful way. Convince patient to take care of the problem, him or herself. No, that's unacceptable. Contact law enforcement. That is when we feel that we are in a threat or our patient is threatening themselves or someone else. So I'm going to protect that patient from harm. Guys, we just did chapter 12. Thanks for sticking it out. I know there was a lot of personal stuff in there, but I that's real life stuff. Um, and it will also play a role in your quizzes and tests. This one's super important. It's super personal to me. That's why I went the route I did. If you have questions, concerns, comments, please reach out. I'm not going to tell you the worst thing I ever seen, but if you need to have examples, reach out to me. I'm happy to visit about my experiences if it helps you not go through them. So I'll get you guys on chapter 13.